So I'm going to cover the PIPJ arthritis and its importance in the hand. Wait, sorry, the PIPJ is the locus of the finger. It's the joint with the largest range of motion in the hand and contributes an estimated 85% in the grasping capability of the hand. The joint is complex, but at its core, it's a hinge with varying centers of rotation, but also some lateral motion and rotation, which is passive. So besides the bony articulating surfaces, the soft tissue components are also important. These include the collateral ligaments, the proper accessory ones that provide lateral stability, as well as the volar plate and the check ring ligaments that provide a volar restraint to hyperextension. So the most common causes of PIPJ arthritis are post-traumatic arthritis, which is the focus of this talk, osteoarthritis and inflammatory arthritis. And less common causes include gout and infection. So there are different surgical approaches to the PIPJ, which I outline in the following order. The most common is the dorsal approach. And this is shown in the central diagram. And it is centered on in the middle of the finger. And at the level of the extensor tendon, you can either split it longitudinally as shown on the left, or use a distally based V-shaped flap as shown on the right. So the next approach is the volar approach, which is less common. And it is useful for fracture fixation and implant arthroplasty. So with this approach, the whole joint surfaces on both sides can be viewed after you shotgun the joint, and it is shown in the diagram on the right. So the final approach is the lateral one, which is useful for some fractures, and also has been described as an alternative to the volar approach for implant arthroplasty. So soft tissue interpositional arthroplasty is one option in PIPJ arthroplasty. It provides an attractive alternative to fusion or implant arthroplasty, as it preserves motion but avoids all the problems with implants. And because there's no shortening of the bone, salvage with fusion subsequently is also possible. However, it's not widely used now, and the data on it is limited. It requires a good soft tissue and collaterals and relatively good alignment of the middle and proximal phalanx. So it's probably best for patients with a lower demand. So personally, I've done it a few times, but I've been disappointed with both the pain relief and motion, so I stopped doing it. This picture on the right is from a technique from Lin, with one variation using the volar plate to interpose. So Gong and his colleagues use a different technique using the FDS for soft tissue interposition. And the advantage here is that the flip of the FDS can also be used to reinforce the collateral ligament and correct deviation. So arthrodesis is a well-established surgical technique for many joints. In the PIPJ, there are different techniques and different implants to choose from, and range from the top left here using wires for a loop and oblique wire construct, or a 90-degree loop construct, or on the top right shown using a tension band wiring construct. Then we have on the bottom left plates and screws, or you can also use a screw-only construct. So in general, arthrodesis is done from the dorsum. But I wanted to share this case from my colleague, who, because of soft tissue reasons, used a plate and screw construct in 2 digits to do the fusion from the volar side. I just want to cover a few technical considerations in fusion. First of all is the angle of fusion. In general, if there's shortening, you fuse the finger in a straighter position. Secondly, as you move from the index to the small finger, from the radial to the ulnar side, the joint fusion angle generally increases, as shown here in the diagram. Finally, you also should need to consider the patient's needs. For example, a guitarist may want the joint slightly more flexed. Secondly, in order to get an accurate angle, the bone cuts must first be accurate. So I prefer the technique shown on the top right, which uses a straight cut using an oscillating saw. But an alternative is to prepare the articulating surfaces in a cup cone fashion. For example, using a rongeur and a burr, as shown on the bottom right. And this alternative is supposed to be more forgiving for angulation and deviation. From a biomechanics point of view, it is unclear which technique is better. So Capo, in one study comparing 5 different constructs, a specialized intramedullary device and plate and screw construct showed the best strength and stiffness. In an earlier study without plates and screws, tension band wiring was shown to be better in the anterior-posterior bending and torsion forces. In my view, all the techniques work, but my favorite choice for fusion is tension band wiring, shown here on the right. And the reason that I choose it is because it is relatively quick to do and reliable in outcome. In addition, it uses inexpensive implants that are non-obtrusive. So the photograph at the bottom is from a technique paper by Uhl describing the process step by step. Overall, PIPJ fusion gives predictable results. The fusion rates are high, more than 85 to 90%. And surgical complications like hardware prominence, malunion, fracture, and so on are reasonably low. From a functional point of view, arthrodesis gives excellent pain relief. And usually strength is better, typically pinch strength. But this is at a cost of loss of motion. But this loss of motion may be less than what you would expect. In Vitale's paper, they report an average of 30 degrees loss of motion in the PIPJ following arthrodesis. This is because many patients already have stiffness before at the time of surgery. So next, I will cover implant arthroplasty for the PIPJ. And there are 2 basic groups of implants, the silastic or silicone implants shown here on the top right, and some form of surface replacement metallic implant shown here on the bottom right. So firstly, silicone implants, which are available for finger joints like the PIP and NCPJ. They have been used in the PIPJ since 1968 and shown to give good pain relief. So as shown in the picture on the right, it is a one-piece implant. So it functions as a spacer rather than a true joint. But there's relatively good longevity and many patients are satisfied with it. In terms of long-term outcomes, this paper showed that there is good pain relief even at 10 years and patient satisfaction. And overall implant survival rate is about 90% at 10 years. But you need to understand that during this time, the range of motion remains unchanged from pre-op. And on radiography, changes do progress. And this includes progressive deformity, such as in the radiograph shown here, as well as fracture of the implant. But overall removal and rate is about 10%. And some of the patients with fractures will keep the implants in situ. And it is best indicated for older, lower demand patients. Metal implant arthroplasty is newer than silicone, and there are many designs. It gives good pain relief, but despite its aim, range of motion is also not markedly increased. And there are higher complications than silicone arthroplasty, such as infections, squeaking, and so on. So Atkinson said in 2014 that there are currently still limited indications for this implant arthroplasty. Young patients with post-traumatic arthritis, no angular deformity, and soft tissue coverage. So while American and European implants predominate, there are Japanese design implants as well. So I'm more familiar with the self-locking finger joint. It has a modular system with a unique bone anchor that is spread open by a locking screw. So as the screw is driven in, these prongs are open even wider and lock into the medullary canal, giving a strong cementless hole. So there's at least one other Japanese implant available called the Ishizuki Total Finger System. So this is a summary of the arthroplasty options. I mentioned, I covered silicone arthroplasty, metal implant arthroplasty, and interpositional arthroplasty. And my colleague, Dr. Ted Lin, will subsequently cover the autologous arthroplasty options. And these are some of its advantages and disadvantages. For direct comparisons of fusion versus implant arthroplasty, this is not well studied. In my view, both currently have a place in treatments as they are differing patients, different clinical problems and functional needs. Some outcomes that have been studied include pain relief, which are comparable, range of motion, which is of course gone in arthrodesis, and there tends to be lateral pinch strength, better lateral pinch strength in arthrodesis. And as I mentioned earlier, implant arthroplasty gives more late complications than arthrodesis. So in summary, I would say that arthrodesis on the PFPJ is a reliable operation for pain relief and correcting deformity. The main issue is total loss of motion of the PFPJ. Although when you look at functional assessment, it's comparable to implant arthroplasty. So I think the good candidates for this are younger and male patients with strength requirement. On the other hand, implant arthroplasty prioritizes motion and also gives good pain relief, but it must be remembered that motion doesn't really increase and tends to decrease over time. It gives more complications and reoperations. And between the two types of implant arthroplasties, silicone arthroplasties are well established. Metal surface type replacement type implants are still evolving. Thank you very much.